Hello. We are now going to transition from what I consider to be basic cardiac ultrasonography in critical care, which is largely a qualitative evaluation, to what I consider to be advanced cardiac ultrasonography in critical care, which is heavily dependent on quantitation and specifically on Doppler echocardiography. So this is going to be an intro and a basic overview into quantitation, quantitative echo, and Doppler echo in critical care. As I mentioned before, most of the time in the critical care setting, when you're trying to evaluate someone who is in shock, for example, a qualitative assessment of the heart is sufficient to figure out things like why a patient is in shock, what to do about it, and then to monitor response to your chosen therapy. But there are many situations that would benefit from quantitation. So that's where we're going to focus our attention on now. Quantitative echo in critical care does a number of things for you, both generally and specifically. In general, what it does is it adds an objective component to your thus far subjective assessment. And it allows you to do things like, for example, predict response to an intervention. Specifically here, we're talking about predicting volume responsiveness. It helps you measure quantitatively, objectively, the patient's response or lack of response to an intervention, response to things like inotropic therapy, diuresis, fluid resuscitation, that kind of thing. And by doing these things, it helps you titrate and optimize your intervention to evaluate your patient and to achieve the goals you're trying to achieve. There's really two big things that quantitation in critical care focuses on. One is the measurement of flow, the quantitation of flow. And the other thing is the measurement of pressure dynamics, whether that be in the ventricles or the atria or leading into the heart. And largely, quantitative echo in critical care revolves around using Doppler echocardiography. So the rest of this talk is really going to be a deep dive on Doppler and how to use it properly. Doppler echocardiography relies on the Doppler effect. You probably remember from high school physics that the Doppler effect is the frequency shift of sound that's being emitted by an object that is moving in relation to an observer. And probably all of your high school physics textbooks had a picture that looks something like this. You got a train moving down a track, blowing its horn. And there are two observers listening to this train horn. There's one observer that's standing in a position wherein the train is moving towards him. And there is another observer that is standing in a position where the train is moving away from him. The train is blowing a horn at a certain frequency, but the frequency that this observer, who's standing in a path where the train is moving towards him, that frequency that he observes is going to be higher than the frequency that's being emitted. And the opposite for the guy that's standing in a path where the train is moving away from him. The frequency of sound that he perceives will be lower than the frequency of sound that's actually being emitted by the train. And that is called the Doppler effect. In the context of Doppler echocardiography, the moving object is usually the red blood cells, but sometimes we're looking at tissue structures as well. The sound wave is not actually being emitted by the object, but it's being emitted by the ultrasound probe. It's being shot into the tissue, it's hitting the moving object and bouncing back. And then the probe sensor itself is acting as the observer. So you have a sound that's being emitted at a certain frequency by the machine through the probe. It's hitting the moving object, and it's bouncing back, and it's being observed at a different frequency. And what we do in Doppler echo is we use the Doppler shift to help us calculate the velocity of the object of interest, okay? So we use this Doppler shift, the difference between the frequency of sound that the machine shot into the tissue and the frequency of sound that the probe sensed when the sound bounced back to the probe, and that is the Doppler shift. Okay, and we use that again, that Doppler shift, to help calculate the velocity of the object that we're interested in. Like I said, usually it's a red blood cell, but sometimes it is tissue structures. So here's the Doppler equation that uses these variables to calculate an object's velocity. It's sort of a long and complicated looking equation, but there's really two key aspects to this equation that you guys should understand. One is that the velocity of the object is directly proportional to the magnitude of the Doppler shift. So the bigger the difference between transmitted frequency and received frequency, the faster the object is moving, or the faster your calculated velocity is of that object. So Doppler shift, the magnitude of Doppler shift is directly proportional to the object's velocity. The other important part of this equation is this right here, theta. And theta, as you can see, is inversely proportional to the velocity. So what is theta? Theta is the angle of intercept between the path of the moving object, let's say the red blood cell, and the path of the sound wave that's being shot at that object by the ultrasound machine. This is sort of demonstrated here. If we look at this is a sort of an angulated four-chamber view, and we're trying to measure the velocity of blood going from the left atrium to the left ventricle. So what we do is we turn on Doppler, and this line here is telling us, when we turn on Doppler, this line is telling us the direction of the sound that's being shot out of the probe into the tissue. And we can move this left and right to change this angle, but this is the direction of the sound that's being shot into the tissue. This blue arrow here is an approximation of the direction of blood flow going from left atrium to left ventricle. The angle between the blue arrow and the Doppler line, this is your theta angle, okay? Your goal as the sonographer is to make theta as small as possible, okay? Because again, the velocity calculated is going to be inversely proportional to the theta angle. So the smaller the angle, the more perfect of an estimation your calculation is going to be to the actual velocity of the object, okay? So practically what we're going for is ideally you're going for a theta angle of 0 or 180 degrees, where the path of the red blood cell is exactly parallel to the direction of the sound wave being shot at it. And if you remember from high school trigonometry, the cosine of 0 or 180 is 1. So if your theta angle is 0 or 180, the velocity measurement is going to be as accurate as possible or as close as possible to the actual velocity of the moving object, okay? So you're going for a theta angle of 0. You should never have a theta angle of 90, okay? Because if you remember from high school trigonometry, the cosine of 90 is 0. And so you will get no velocity measurement if the theta angle is 90. You've probably done this before where you've tried to look at color flow going through a blood vessel that's perpendicular to your probe. You'll see that in that instance, there's actually no color. And the reason for that is the angle of intercept is 90 degrees, so it cannot pick up any velocity in any movement at all. Okay, so the theta angle cannot be 90. Okay, in clinical practice, you want to shoot for a theta angle of 30 degrees or less. Okay, so this is the biggest takeaway from this slide here, is that you as a sonographer have to line up your view and line up your Doppler beam such that theta is 30 degrees or less. Okay, this is why when we talk about axis, when we sort of perseverate on angles and things like that, it's for this purpose. Okay, so for example, in your apical four-chamber view, if you line up your septum to be vertical up and down, like I've told you guys to do over and over again, that's going to make your theta angle when you're doing something like Doppler down the LVOT be as small as possible. So this is why angle is so important, not only for your qualitative assessment, but that much more so for your quantitative assessment using Doppler. Okay, so big takeaway point, actually two of them. One, Doppler shift directly proportional to velocity. The more practical takeaway, your theta angle should be 30 degrees or less, okay? So there's three modes of Doppler that we use in critical care. One is a mode that you will have already used when you're doing your qualitative assessment, that's color flow Doppler. So think of color flow Doppler as your qualitative Doppler mode. For a quick review, color flow tells you really three things. One, it tells you the magnitude of flow, so how much flow there is. If you see a lot of color, there's a lot of flow. If you see not so much color, there's not so much flow. It tells you the direction of flow, the way that I think pretty much all ultrasound machines are set up. If the color is blue, that is telling you that the flow is going away from the probe. If the color that you see is red, that's flow moving towards the probe. So it tells you direction of flow. It also tells you whether the flow is laminar, which would be single color, or if the flow is turbulent, which would result in a multicolor or a mosaic appearance to the color flow signature. Okay, so there are some situations where identifying turbulent flow where there should be laminar flow gives you a lot of clinically useful information, specifically when you're trying to evaluate for evidence of Hocum physiology. Okay, so this is color flow Doppler. This is your qualitative mode, and we've gone over this when we've talked about our basic cardiac assessment. Okay, the next two modes are your quantitative modes. There is pulsed wave Doppler, or PW, and continuous wave Doppler, or CW. Okay, and this refers to the way in which sound is being shot into the tissue. With pulsed wave, they're being shot into the tissue in discrete pulses, whereas in continuous wave, it's more of a continuous generation of sound. Okay, the practical difference between the two is that if you're trying to measure the velocity of an object or the velocity going through a specific point in your heart, for example, then you use pulsed wave Doppler. So for example, if you're trying to figure out how fast is blood moving through the LVOT, this point right here, you use pulsed wave Doppler. If your goal is to measure the maximum velocity along an entire track, then you use continuous wave Doppler. So if your question is what's the peak velocity from ventricle to atrium when we're looking at tricuspid regurg jets, then you use continuous wave Doppler. And the way I remember it, pulsed wave and particular point both have a P in it, and continuous and maximum do not. Okay, so pulsed wave, particular point. There's really four big applications for Doppler in critical care, and these really are listed in order of frequency of use. We use Doppler to measure or calculate left ventricular stroke volume, probably the most commonly used method in most situations. We can also use it to measure right-sided pressure dynamics, RV systolic pressures, PA systolic pressures, mean pressures, diastolic pressures, and so on. We use Doppler to identify the presence of pulsus paradoxus. This is when we're trying to identify evidence of tamponade physiology early on in the evolution of tamponade. And finally, we can use Doppler to help us estimate left ventricular filling pressures. So these are the four big applications that we're going to talk about in subsequent lectures. As usual, if you have questions, come and find me or shoot me an email. And until then, I look forward to scanning with you.